What I'm going to talk about is an example of incremental changes, which of course are very important and useful and form the majority of advances in medical research. But transformative changes are the kind of things that can arise out of a meeting like this, where someone with a prepared mind can leap across lines of disciplines and specialty and technique and really make a non-intuitive leap. So I'm going to talk really basically about clinical work here. So the different therapies I like to talk about are the use of intraoperative MRI in brain tumor surgery, as well as clinical trials for new agents to treat patients with newly diagnosed gliomas and with metastatic tumors. I've been working with intraoperative MRI now for over 9 years, and all of you have either used MRI in some way or have had one done, or a family member, and you're used to thinking of diagnostic MRIs, which of course are large and complex devices, and you'd think, how or why would you want to bring that into the operating room? Well, there are a bunch of reasons. When we do intracranial surgery, we rely on preoperative information from CT, or more often nowadays MRI, to navigate, to point to a spot on someone's head and show us where we are in the image, so that parts of the anatomy that are not obvious to the naked eye or even to magnified vision can be identified precisely. You can identify your path to a tumor, you can make sure you're not near so-called eloquent brain, and so on. But once you open someone's head, as you can see here, let me get that cursor to work. This is after opening the dura, and nothing else has happened to this patient. Well, of course, the scalp and the skull were opened, but normally the brain would come and fill this whole space. But after letting some spinal fluid out, tilting the patient's head up a bit, you can see the brain shift down, and the sphenoid wing is exposed for at least 2 centimeters. So if you're relying on information from a preoperative MRI to show you where you are in the brain, you can potentially do more harm than good in your surgery. So that's one advantage of intraoperative imaging. The other more obvious advantages include resection control, so that if your goal is to, let's say, take out a tumor, you can know that you in fact took out the tumor. And complication avoidance, if your goal is not necessarily to remove a whole lesion, but to take out a certain amount and avoid critical areas, that you will know when to stop. And it's basically mirroring the whole evolution of operative neurosurgery over the last 110 years or so, which is to avoid guesswork, going back to X-rays and angiography and CT, and more recently, MRI. So speaking of evolution, I'd like to give a nod to the grandfather of intraoperative MRI, which was developed at the Brigham and Women's Hospital. It came online in 1995, not so new anymore. This was a joint project between the Surgical Planning Laboratory at the Brigham and General Electric Medical Systems. And no one had really conceived of this before. It was really an amazing science fiction-like scenario, the idea that you could actually do surgery in an MRI. You look at these pictures, you could see that there's an ergonomic obstacle to operating in this kind of environment. It's very narrow ingress for the surgeon. It also made positioning difficult for neurosurgery, and instruments had to be specially designed for this environment. In fact, it took them a year to design a scalpel. That was the hardest thing. The drill, the microscope, no problem. You know, they got people excited to build little ceramic motors and that sort of thing. But a scalpel was very difficult until they came up with a suboptimal ceramic scalpel.